In the final portion of our talk on lightning-related injuries, we'll delve more into the types of specific injuries that can be sustained, their long-term sequelae, and then what can we do to manage a patient or person that's been struck by lightning. Now, it's important to remember that lightning strikes are neither direct current or alternating current, but just a unidirectional impulse, an extreme discharge of power. And essentially, it's the flow of electrons over and through the body over an extremely short period of time that can cause a multitude of injuries from essentially short-circuiting the body. Overall, cardiopulmonary arrest is the most common cause of death, most frequently due to asystole from the electrical charge stunning the SA node. But there also is a component of respiratory arrest. It's believed that in many situations, the heart will begin to contract again as the SA node recovers from the electrical current. However, the respiratory center of the brain takes a longer period of time to overcome and recover from the electrical shock. This is why, as we'll discuss later, it's important to provide rescue breathing even if the patient regains a pulse in a patient who has sustained a lightning strike. Now, in addition to asystole, you can result in ventricular fibrillation secondary to the lightning strike as well. Now, what can we see in regard to the cardiovascular system in a lightning strike victim? Well, we might see EKG changes, AFib, VFib, elevated biomarkers. You might see pericarditis, autonomic instability, labile blood pressure, or pericardial effusion. It should be noted that those last three with the asterisks, those generally are delayed in presentation or might last for several months. And at the top of this slide, we mentioned ST elevations. Now, what's interesting is not all of these patients will have coronary lesions on angiography. So it's hard to know exactly what's causing those ST elevations other than potentially direct myocardial damage. It's important to note that on this slide, these findings tend to be more commonly associated with an indirect strike, and asystole and ventricular fibrillation more common with a direct strike that we saw on the previous slide. However, any strike can present with any of these findings. Now, how should we manage lightning strike victims in relation to the cardiovascular system? Per the Wilderness Medical Society guidelines, high-risk patients, as indicated in the table to the right, require ECG and echocardiography. Patients that lack any of these do not require screening tests, but most providers will at minimum perform an ECG in all lightning strike victims. Most would recommend that if you have sustained a direct strike or have any abnormal findings on your ECG or echo, to undergo 24-hour telemetry monitoring to watch out for any of the complications that we discussed in the previous slides. Now let's move on to the neurologic system. Some complications related to the neurologic system in a lightning strike victim are confusion, anterograde amnesia, apnea, as we briefly discussed earlier, seizures, intracranial hemorrhage, either due to the direct concussive force of the strike or secondary to trauma when the patient was thrown, and cranial burns. If a patient has sustained a cranial burn, they are at a 3 times increased rate of death. The electrical current will enter the brain through the orifices of the skull and generally will hit the brainstem. When it does, the respiratory center will become paralyzed. But that paralysis, thankfully, is generally transient. So if we're able to overcome the hypoxia that will develop from that, we can potentially save the victim's life. Now, in relation to seizures, some will only last several days, and most are not long-term. A unique phenomenon related to lightning strikes and the neurologic system is coronal paralysis. This essentially is a transient paralysis, potentially due to a vascular spasm, but has a few unique features on physical exam. The extremity, usually the lower limbs more than the upper limbs, will tend to be pulseless. They'll exhibit pallor or cyanosis and have motor and sensory deficits. So it's important when examining a lightning strike victim to check the central pulses, because you may not feel a pulse if you're feeling the pulse on a limb affected by coronal paralysis. Similarly, it's important to always utilize spinal precautions in these situations because even though a paralyzed limb might be due to coronal paralysis, you cannot rule out spinal cord injury until you further or better assess the patient. Now, unfortunately, there are some long-term sequelae associated with lightning strikes in the neurologic system. You can have memory impairment, sleep disturbances, emotional lability, aggression, difficulty concentrating, and depression. Now you'll notice that many of those are related to psychiatric disease, and some are very difficult to deal with. This is a picture of Roy Sullivan. He was a park ranger at Shenandoah National Park. He had a confirmed 7 lightning strikes starting in 1942. In the picture, you can see the charring on his hat from such a strike. Now sadly, he died from a self-inflicted gunshot wound at age 71, and some speculate that it was because of psychiatric instability secondary to frequent lightning injury, though others speculate it was actually due to a lover's quarrel or unrequited love. In regard to the dermatologic complications or problems related to a lightning strike, there's something called ferning. And as you can see on the picture here, there's what is known as a Lichtenberg figure. And this is not a true burn in the classic sense, but is actually a showering of electrons over the skin. And we know that it's not a true burn because there's no histological changes when these are biopsied, as you would see in a burn. And if you paid close attention to last presentation, or the last portion of this presentation on lightning-related injuries, it seems to look very similar to a ground current spreading out from a central axis. You can also get linear burns, usually secondary to steam production when the moisture on your skin actually vaporizes instantaneously from the charge. Generally, these will be first or second degree burns. You can also get punctate burns. These are very closely spaced, and this is believed to be from current passing out of the skin from deeper underlying tissue, sort of an exit wound. And as we mentioned in the last presentation or the last portion, there is also thermal injuries. This generally happens that metal jewelry becomes superheated during the lightning strike and can cause thermal contact burns. Lightning has also been known to melt clothing, and sometimes these thermal injuries can be deep, extensive, and severe. And that is why it's recommended that you should remove all metal jewelry or metal objects touching your skin if caught in a thunderstorm. Let's move on to the eyes and ears. A lightning strike victim can experience transient vision loss and pupil dilation. So that is why when assessing a lightning strike victim, it's important to note that fixed pupils do not equal brain death. Similar to apnea, as we'll discuss more in a moment, does not equal death. You can develop prolonged visual problems, possibly due to optic nerve injury or retinal damage from the lightning strike. And most people, or many people, will develop cataracts, some as early as 2 days after the injury, some as late as 4 years post-injury. In general, the most common ear injury will be a ruptured tympanic membrane, which occurs in about 30 to 50% of the lightning strike victims. However, there can be deeper ear structures involved, resulting in damage to the ossicles or the mastoid. Let's spend the last portion of our topic talking about the triage and resuscitation of lightning strike victims. Now, normally in a mass casualty situation, we do not attend to those without a pulse or spontaneous respirations. They are black tagged and considered non-viable. However, due to the pathophysiology of lightning strikes and the way that it affects the SA node and the respiratory center, we actually want to initiate assisted breathing or full CPR on these patients. The hope is that we can prevent the development of hypoxia while we're waiting for the SA node to kick back in and the respiratory center to start breathing spontaneously again. Overall, mortality from cardiac arrest is much lower in these patients as compared to cardiac arrest in the general population, and death is pretty rare if a patient survives the initial strike and we can prevent hypoxia. Before you go triaging and resuscitating these patients, ensure that there's no residual electrical activity in the field, and it is prudent to cease any CPR efforts after 20 to 30 minutes without regaining a pulse or spontaneous respirations. Let's summarize the topic of lightning-related injuries. Remember that prevention is key. Seek shelter if you hear any thunder and stay there for 30 minutes after the thunder ends. It's important to seek shelter. That can be in a grove of trees, in a large building, a car, but be sure to avoid isolated towers or trees and avoid open shelters. When in a group and unable to find appropriate shelter, space yourselves out more than 20 feet. The lightning position is important to learn, but should be used as a last resort and overall is not considered reliable. Utilize reverse triage in mass casualty situations for apneic and pulseless patients. Coronal paralysis can mimic spinal or cerebral injuries as well as vascular compromise, so it's important to note that it is transient and note that it is associated with lightning strikes. Finally, the Lichtenberg figure or ferning is commonly seen but is not a true burn.